Hello my dear students, welcome to the new session. This is again one more session on the multiple choice questions on pharmacology, and we start with the session. The first question on this session: hypertensive emergency is treated with spironolactone, nitroprusside, verapamil, hydrochlorothiazide and methyl-dopa. We're talking about hypertensive emergency. We want to use a drug which is going to decrease the blood pressure emergently, and the best possible way to do it is to use a drug which dilates the venules as well as arterioles both. And if you look at all these drugs, you have a drug on this list which dilates the arterioles as well as venules, and it does it emergently with a rapid onset of action, and the name of the drug is nitroprusside. Sodium nitroprusside is used by continuous intravenous infusion in hypertensive emergency. But probably this question could have been altered by putting another drug which I have shown you on this slide, and that's nitroglycerin. This is very commonly used, and in place of nitroprusside it could be nitroglycerin. We go to the next question is: which of the following should be avoided in a patient having hypertension and asthma? Examples: atenolol, metoprolol, esmolol, propranolol and bisoprolol. So all these are beta blockers, and as you know, when it's a beta blockade, it's going to block the beta 1 receptors in the heart, beta 2 receptors in the bronchus, and this is going to lead to bronchospasm. So if the patient suffers from bronchial asthma, you want to treat his hypertension, it's not good to go for beta blockers. They are likely to precipitate the bronchial asthma. Now the exam is trying to ask you which one is the worst agent amongst this when it is hypertension and asthma. So we try to choose a drug which is a non-selective beta blocker, which will be acting on beta 1 and beta 2 both the receptors, and that is going to worsen the situation the most. If the drug is a cardioselective beta blocker, acts predominantly on the beta 1 receptors, then this worsening of bronchial asthma will be comparatively less. So let's have a look at the drugs. Atenolol, esmolol, metoprolol, propranolol and bisoprolol. So if your classification is good, you would easily understand atenolol, esmolol, metoprolol and bisoprolol. All these are cardioselective beta blockers. Only propranolol is a non-selective beta blocker. So this should be avoided if the patient has hypertension as well as asthma. So look at the answer, that's propranolol. On this slide I have given a list for you to study. Cardioselective beta blockers are atenolol, esmolol, metoprolol, bisoprolol, and non-selective ones are propranolol, nadolol, timolol and sotalol. So propranolol is a non-selective beta blocker which is there as an answer for this question. Let's move to the next question. Next question is: fastest acting depolarizing skeletal muscle relaxant is? You have a list: mivacurium, pancuronium, succinylcholine, D2-bocurarin and dantrolene. Fastest acting depolarizing agents. If you look at all these names, dantrolene is directly acting, it's not very fast acting. Succinylcholine, D2-bocurarin, pancuronium, mivacurium. Out of all this, D2-bocurarin and pancuronium are neuromuscular blocking agents. And if you go to mivacurium, this is also a neuromuscular blocking agent. And the question is about depolarizing skeletal muscle relaxant. So it has to be a partial agonist of acetylcholine, and if you go by this logic, you get a drug which is a choline, that's succinylcholine, and as you know is the fastest acting depolarizing skeletal muscle relaxant, and it's commonly used for endotracheal intubation, obviously. So the answer is succinylcholine. Let's go to the next question. Which of the following inhibits uric acid synthesis? We are discussing a disease which is called gout, in which you have hyperuricemia, right? Which inhibits the uric acid synthesis? Options: colchicine, probenecid, chloroquine, allopurinol and sulfenpyrazone. These are the options. The first option is colchicine, and if you remember your gout classes, colchicine has got very specific anti-inflammatory effect only in gout. So it's not doing anything to the uric acid synthesis, it's not doing anything to the uric acid excretion. So it produces a specific anti-inflammatory effect and is useful in acute gout, as well as you can put the patient on long-term colchicine it can prevent the attacks of gout. So that's colchicine. The second drug is probenecid, and I hope you know probenecid is a uricosuric drug, is going to increase the excretion of uric acid. Along with probenecid, let's see if is there a drug which has got similar action. Chloroquine, allopurinol, sulfenpyrazone. This is also uricosuric. So probenecid and sulfenpyrazone are uricosuric agents. They don't inhibit the uric acid synthesis. Next drug here is chloroquine. What is this chloroquine doing here in these 5 drugs? Where do you use chloroquine? For arthritis. It's rheumatoid arthritis. It's not gout. So it's used as a disease modifying anti-rheumatic drug, DMARD, in the management of rheumatoid, and has nothing to do with this question. So chloroquine is out. So we are left with allopurinol. What is allopurinol? Allopurinol is a xanthine oxidase inhibitor. And if you remember the steps of uric acid synthesis, hypoxanthine to xanthine and xanthine to uric acid. And the enzyme is xanthine oxidase. Allopurinol inhibits xanthine oxidase and it inhibits uric acid synthesis. So, answer for this question is allopurinol. Next question on this session. Out of the drugs mentioned below, which is the most sedating antihistaminic? So you need to know that there are antihistamines which are sedating, the older ones, and the newer ones, generation 2, are comparatively less sedating. Let's read the options. Fexofenadine, cetirizine, loratadine, diphenhydramine, and astemizole. So let me remind you, cetirizine is very commonly employed. This was a very popular agent at one point in time because it was a non-sedating antihistamine or less sedating antihistamine. After cetirizine came fexofenadine. This was popular for many years. And nowadays what we use is loratadine or desloratadine. So fexofenadine, cetirizine, loratadine, all are from the group of generation 2. That's the less sedating antihistamine. And if you go down astemizole, it is also from the generation 2. So we are left with diphenhydramine. If you read your chapter of antihistamine, probably in the classification, you will get this as the first drug, which is very potent and very sedative, diphenhydramine. So most sedating antihistamine out of these 5 is diphenhydramine. All rest of the 4 are less sedating antihistamines. Next question. Physostigmine is useful in myasthenia gravis, reversal of neuromuscular blockade, Alzheimer's disease, atropine overdose, and AV block. We have 5 options here and we want to address what's physostigmine. Physostigmine is a reversible anticholinesterase agent. Reversible anticholinesterase agent. And it penetrates, it crosses the blood-brain barrier very nicely and it can go to the central nervous system. What are the other reversible anticholinesterase agents? One is neostigmine, then the longer acting is pyridostigmine. And if you know about these drugs, the neostigmine, pyridostigmine, and hydrophonium, these drugs, they have a more specific action. They have a direct agonistic action on the nicotinic receptor. And the nicotinic receptor is present in the skeletal neuromuscular junction. So, neostigmine, pyridostigmine, hydrophonium, these kind of drugs which have got that direct agonistic effect on the skeletal muscle will be obviously used for conditions which are related to the skeletal muscle. And the option A is myasthenia gravis. So obviously all those drugs are useful in myasthenia gravis and not physostigmine. Option B is reversal of neuromuscular blockade. Are you getting it? So again, it's a nicotinic receptor site, the same site which we are talking about. So if you have given muscle relaxants during surgery and after the surgery, if you want to reverse this muscle relaxation, you need a drug which is going to go to the nicotinic receptor and is going to concentrate acetylcholine there and will reverse the action of the muscle relaxants. So again, there will be drugs like neostigmine and hydrophonium for reversal of neuromuscular blockade. Next option is Alzheimer's disease. As you know, in Alzheimer's, there is acetylcholine deficiency and we need to concentrate acetylcholine in the central nervous system, and we can use anticholinergic agents for this. But there are specific drugs which have got best penetration across the blood-brain barrier, and I hope you remember the drugs donepezil, rivastigmine, galantamine. These are the drugs which are used for Alzheimer's disease, not physostigmine. We are left with two options, atropine overdose and AV block. What is AV block? There is decreased conductivity in this particular situation, and the examiner is asking, can I use physostigmine for this? Physostigmine is a cholinergic drug and is obviously going to suppress the heart. So this AV block is exactly the same, and it's going to get aggravated. So there's no question of AV block in these options. So we are left only with atropine overdose. And important thing you have to remember is physostigmine crosses blood-brain barrier. Atropine also crosses blood-brain barrier. So physostigmine is effective to reverse the central effects of atropine overdose. And this is why the answer to this question, physostigmine is useful in atropine overdose. That's your answer. Next question, that's question number 17. Choose the most appropriate pair of enzyme and its inhibitor. So there are pairs. There's an enzyme, in front of the enzyme there's a name of a drug, and you have to identify whether this drug inhibits this enzyme. Let's start one by one. 5-lipoxygenase montelukast. This is about leukotriene synthesis, because the enzyme 5-lipoxygenase, this lipoxygenase pathway leads to leukotriene synthesis, and if you stop the leukotriene synthesis, these drugs could be useful in bronchial asthma. So this montelukast is useful in bronchial asthma, but the question is, does it inhibit the 5-lipoxygenase enzyme? If you remember the leukotriene pathway, 5-lipoxygenase is inhibited by a substance called xylitol. And when leukotrienes are synthesized and they're acting on the leukotriene receptor, montelukast and zafirlukast, they block this receptor. So they are leukotriene receptor antagonist. So montelukast is not inhibiting the enzyme 5-lipoxygenase. Next one is GABA transaminase valproate. Do you remember that sodium valproate has got action through GABAminergic mechanism? Yes. So this answer is most likely because it can inhibit the GABA transaminase. Then GABA is going to accumulate, and this will be useful in the management of epilepsy. So this is most likely, but let's screen through the other options. Monoamine oxidase, carbamazepine. Do you feel anything is related? Carbamazepine is anti-seizure drug. And try to remember the monoamine oxidase inhibitors so that we have a rapid revision of those drugs. Monoamine oxidase inhibitors are tranylcypromine and isocarboxazid. Obviously, it's not carbamazepine. Next enzyme is phosphodiesterase, and this phosphodiesterase enzyme is related to cyclic AMP, and they have given in front of it diazepam. No way concern. Diazepam is a benzodiazepine and it's a sedative hypnotic. Next option is cyclooxygenase, and in front of cyclooxygenase it's cromolyn. Do you remember cyclooxygenase? It is the other enzyme in the arachidonic acid metabolism after 5-lipoxygenase, which we discussed just now. So cyclooxygenase leads to synthesis of prostaglandins. So cyclooxygenase is inhibited by the NSAIDs or aspirin-like drugs. It's not cromolyn sodium. So whatever we expressed as the possibility is coming true, and the possibility that we considered GABA transaminase valproate can be endorsed now, can be confirmed. So the answer to this question is GABA transaminase valproate. Want to suggest you something. Did you think about pharmacology in more depth? Did you come across so many enzymes, so many inhibitors? There are so many drugs which are inhibitors of the enzymes inside the body, and that's the mechanism of action of that drug. If you know the enzyme, which enzyme it inhibits, you immediately come to know what is this drug doing. I want to suggest you something. You start making a list. On the left side, left column, write the enzyme, and the right hand side column, you write the inhibitor. And you will be surprised you will find at least 45 to 50 pairs of enzyme and inhibitors. And if you prepare this particular list, enzyme and inhibitors, probably you will be able to answer 50 different topics, because there are 50 different drugs which inhibit the different enzymes. One more reminder for you: whatever videos you are listening to and you are watching, go to the pharmacology and go to the general pharmacology videos. Whatever I suggested you right now, to make a list of those 50 enzymes and to find out, my dear students, I have already done it for you. You'll be surprised. I have already done it on the pharmacology, general pharmacology module. Go to that particular video and have the list, enzyme and inhibitor, prepare it thoroughly, and it's going to be extremely helpful to you for the examination. So this is about the enzyme and inhibition. This was GABA transaminase valproate. Let's go to the next question, 18. Zolpidem. Zolpidem, options: is used to treat anxiety, has minimal abuse liability, produces insomnia, is a newer anti-epileptic, and blocks opioid receptor. Think about zolpidem. The spelling is starting with Z. Does it remind you anything? That those drugs starting with Z, there are 3 drugs and they are all called Z drugs or Z drugs: zolpidem, zaleplon and zopiclone. Where did we learn it? Are they benzodiazepines? Not really. They are non-benzodiazepines and they are sedative hypnotics. And instead of using benzodiazepine, you can use these 3 drugs as sedative hypnotics, and the advantage is their abuse liability is least. That's the major problem with the use of benzodiazepines. If you want to put the patient on these benzodiazepines for a long period of time, you will have to worry about how to stop the drug, because this drug has abuse liability. And non-benzodiazepines are better because the abuse liability is less, plus the non-benzodiazepines are helpful to increase the types of sleep which is called as deep sleep. That's either stage 3 sleep or stage 4 sleep. So zolpidem, zaleplon and zopiclone are the newer benzodiazepines with less abuse liability. If you prepare this idea in your mind, then it's not difficult to solve this question. Is used to treat anxiety? No, it's not an anti-anxiety drug. Has minimal abuse liability? Yes, that's right. Produces insomnia? No sir, it doesn't produce insomnia. It's used to treat insomnia because it's a sedative hypnotic agent. Is a newer anti-epileptic? No, it's in no way concerned with epilepsy. And the last choice is blocks opioid receptor. No, it does not have any additional effect on opioid receptor. So we resolve by saying that zolpidem has minimal abuse liability. I'm showing you the answer. Minimal abuse liability. Let's move on to the next question. Next question is again about benzodiazepines. Benzodiazepine overdose is treated with, and there are 5 options. Naloxone is one, flumazenil, second one. The third one is pentazocine. The next one is disulfiram, and the last one is physostigmine. So we have 5 drugs here, and you know the for benzodiazepine overdose we have a specific antagonist available, and the name of the antagonist is flumazenil. If you still don't know it, you need to prepare it. It's a very high yield question. What's the treatment for acute benzodiazepine overdose? That's flumazenil. Let's screen through the other options. Naloxone. Do you remember anything? Naloxone is an opioid antagonist. Naloxone is the drug of choice for morphine poisoning. The next drug is pentazocine. What's pentazocine? It's a mixed agonist antagonist of the opioid receptors. So if it's mixed agonist antagonist, it's not useful to treat any poisoning. Next drug is disulfiram. And as soon as we say disulfiram, you remember alcohol. But disulfiram is not used in acute alcohol overdose. It is used in the management of alcohol addiction as aversive therapy. So that's disulfiram. And the next one is physostigmine. And I hope you remember this is a cholinergic drug. So it will be useful in the poisoning by the anticholinergic drugs. So physostigmine is used in atropine overdose. So we could know the uses of the other options which are also not right on this particular session. So, benzodiazepine overdose is treated with flumazenil. With this question, a friendly advice to you: prepare list on one page the drug and its antagonist, rather antidote, the drug, and for this poisoning which antidote is most commonly used. And now you should not be surprised. Once again, go back to the video lectures which we have prepared for you for pharmacology, and go to general pharmacology, and you will also find the list of the poisons and the antagonists. That will help you. Next question. The next question is the last question of this session. Which of the following atropine substitutes is used as a pre-anesthetic medication? Answers: trihexyphenidyl, ipratropium, glycopyrrolate, dicyclomine, and cyclopentolate. It's good that this question came to us. It's giving us an opportunity to know a bit about all the atropine substitutes and the uses of all the atropine substitutes for various conditions. Atropine is a very important pre-anesthetic medication. But as you know, we have noted certain drawbacks with atropine. For example, non-selectivity of action, long duration of action, and this is why we have many atropine substitutes. And if you look at the clinical practice, most of the times we are using atropine substitutes, and this is why they are important. Amongst the atropine substitutes shown on this particular slide, the first one, trihexyphenidyl, it crosses the blood-brain barrier, enters the central nervous system, and it is useful for management of Parkinson's disease. Especially the anticholinergics are useful for drug-induced Parkinson. The next one on the list, ipratropium. Along with that, there is another friend of it, that's tiotropium. Ipratropium, tiotropium, both are available by the route of inhalation for the management of bronchial asthma, because they dilate the bronchus just like atropine, but dryness is comparatively less. The third one is glycopyrrolate. It can have many other uses, but the most important use is it is given before anesthesia, before surgery, as a pre-anesthetic medication, and is going to produce same effects as atropine, with an advantage that the tachycardia will be comparatively less. Next, we have another drug, that's dicyclomine, and this is a very popular drug to be used when you get abdominal pain. Sometimes you call it cyclopam. So it is that dicyclomine. So it's in the group of propanthyline, methanthylene, oxyphenonium bromide, pirenzepine, etc. These are acting on the M1 receptors, and they are useful as antispasmodic agents. The last agent, cyclopentolate, is very popular and it's very widely used. Let me remind you of the eye. When you want to test the refractory error in the eye, you want to dilate the pupil, and you also want to produce paralysis of accommodation. So you can, in place of atropine, you can use these agents, atropine substitutes, because their duration of action is short. If you put atropine, is going to act for a long time. Sometimes the mydriasis can last for 3 days, and the cycloplegia can last up to 5 days, and this patient is going to suffer from blurriness of vision for such a long time. Naturally, we need some good drugs, and we have two important drugs in this group, tropicamide and cyclopentolate, plus you have homatropine and eucatropine. So cyclopentolate is used in the eye as a mydriatic and cycloplegic agent. So we went through all the groups of atropine substitutes. We took an opportunity to do it. So which of the following atropine substitutes is used as a pre-anesthetic medication? The answer is now obvious. It's glycopyrrolate. So we have come to the end of this particular session, and I hope you enjoyed this session. I too enjoyed with you, and I wish you good luck, and thanks for listening.